So I would like to welcome back Erin to continue with where we left. And I believe this is our third session since when we started the supportive care echo. So I would like to welcome Erin to introduce yourself and then to continue from here.
Yes, thank you so much, everyone. And we're going to start our session right away today because we're actually talking about a very big topic related to supportive care. So the content is heavy today, but I'm hoping that through some discussions and interaction over the chat, we can go through the content together. So we're going to start with the topic of pain management for today in kidney supportive care. As you know, I'm Erin, and I'm a palliative care nurse and helping lead the supportive and palliative care program here at AHN. So as we think about kidney supportive care, I do want to give credit to the ISN. They have an academy online in which we were able to adapt some of the content for our training at AHN. So there is a link here, and then in the last few slides in the references, you can also see a link there to their online program. It is a free program. It's set up to be self-paced. So if you're interested in going through that course, you're welcome, and you would get a CME accredited, I think it's 2 hours credits, which is really great. So by the end of this session today, I'm hoping that you'll be able to understand the importance of pain assessment as well as management for our kidney failure patients, recognizing as well as assessing some common symptoms experienced by patients related to total pain. So we'll talk about that, might be a new concept for you. And we hope that you'll be able to implement a variety of approaches for managing symptoms, both focusing on pharmacological, so medication, as well as non-pharmacological ways of addressing pain. So by the end of it, we hope that you'll become more competent in utilizing effective pain assessment tools, techniques, and applying that to manage pain in your patients. So as we get started today, I want you to understand that pain is actually the most common in dialysis patients. It's found approximately in 50% of our patients. We know that it's widespread, that many of our patients are not treated for pain, and it does unfortunately negatively impact their quality of life. Pain that occurs in kidney failure patients can happen for many reasons, and it can also happen at any time. What has resulted, though, is that patients often don't admit that they have pain or even share their symptoms. And that's what we're going to get at today, how it's so important that we ask our patients about pain. And some people have said that pain is the fifth vital sign, that we do really need to ensure that we monitor, assess, and treat pain very similarly to the way we do that for the other vital signs. And this is taken from an article that was written in 2021 on symptom management for patients among those with chronic kidney disease. So there's several causes of pain. So we know that for patients with kidney failure, they often have comorbid health issues. So we know that most pain in kidney failure patients is related to the following reasons that I've mentioned here. So musculoskeletal pain. So it could be osteoarthritis. We know that some of our patients are older, so they may have a history of arthritis, osteoporosis, renal osteodystrophy, osteomyelitis, or even carpal tunnel syndrome. So that often happens in the hands of our patients. Pain can also be related to dialysis, the treatment in general. It can also be caused by neuropathic pain. And we know that many of our patients have diabetes, in which they can experience peripheral neuropathy and can have symptoms of pain. Can also be from ischemic pain due to peripheral vascular disease. So again, our patients can have issues with their circulatory system causing pain. And then as well, angina. So heart pain or cardiac pain can also be causing pain in our patients with kidney failure. Some other reasons could be polycystic kidney disease, a malignancy or cancer, calciphylaxis, and also trauma. So we know there's a wide variety of reasons that our patients experience pain, and this is just a basic list to show what are some of the main reasons. Some important concepts to remember over the next, hopefully 30 minutes or so as we do our teaching. When we think about pain, and especially palliative care, we often talk about treating pain in patients with advanced cancer. And oftentimes there's some very basic teaching that we do. For our kidney patients, we know that there are specific things that we must avoid, and we must be very careful and be very diligent when we prescribe these things. So in general, if you attended a palliative care course or you've done some extra palliative care training, you might have seen that we talk a lot about morphine and opioids for advanced pain. For our patients, we know that the way that they filter out most opioids is through their renal system. So we need to be very careful. So therefore, I want you to remember to avoid codeine for your patients when you're prescribing or you're speaking to the specialist. Try to avoid morphine as well. I know in Kenya, we don't have a lot of access to a wide variety of opioids. So oftentimes morphine is actually our only option. But if you do have access to other opioids, which we will go into further detail over the course of this teaching, try to avoid morphine then. Use the other ones that we recommend. We usually say only to use it in smaller doses is if you have to. So start low and go slow. And again, this is because the active metabolites in these drugs are excreted through the kidneys. Again, also NSAIDs, so non-steroidal anti-inflammatories, can actively worsen our patient's renal function. So it's really important. We only prescribe these once we've spoken to the treating physician. So their nephrologist or the medical officer that's supporting the case. And we want to use adjuvant analgesics. So again, some of these terms might be new terms for you today, but I will be teaching about it. So again, we use those as needed. So first question for the chat and for those of you who've joined in today, how do we ask our patients about pain? What do we do? How do we figure out how much pain they have? What have you done in the past, or what have you heard? How do you ask your patient about pain? So you can put it in the chat. I see Anson has joined. Welcome, Anson. For sure. How do you feel today? How is your pain? Very good. I really like that you've added in today. Sometimes we can have patients who have chronic pain. So I think it's really important that you specified when. What are you talking about? Using a scale. Very good. 1 to 10. That's a very, very common way to ask people about their pain. Yeah, for sure. These are really good starts. So it's really important as we think and consider talking to our patients about pain is that we understand the consequences as a team about untreated pain. So here you can see a woman. This is a picture from the empath team, a person who's doing a home visit for someone with advanced cancer. Here you can see for patients we know that have untreated pain, anxiety, depression, increased suffering, and even a decrease in their quality of life can occur. This is one of the biggest reasons we want to figure out how to talk to patients about pain. How do we ask them? How do we help them rate their pain? How do they score their pain so that we can better know how to treat it? Because untreated pain often occurs and results in these things that I've just mentioned. Yeah, very good, Lillian. On a scale of 1 to 10, where would you classify your pain? Really good. How long has it occurred? Perfect. So more descriptive questions about the pain to get a better understanding of what it looks like for that patient. Really good. Okay, good communication is also really, really important. We need to make eye contact with our patients. We can't expect them to share something very specific with us if we're not even looking at our patients. So make sure you make eye contact. Again, introduce yourself. If you are a clinical officer, make sure that the team knows who you are. If you're the regular nurse, again, you can just introduce yourself and say that I'm your nurse for today, and I'm going to be asking you some questions about your pain. Explain what you want to do. So you want to understand the symptoms that your patients have, and then definitely using words that a patient can understand. So using Swahili, using a local language, depending on which area you're working in, can be really helpful. There often are words for pain in other languages. As we get into the more descriptive words about pain, that the pain is tingly or numb or sharp, again, that might be more difficult, but think of how you would try to get the best description of pain from your patient. And it could be using a caregiver to support that as well. And definitely making sure that you explain to the patient how much you can help and how quickly the treatment will work. So really reinforcing that we're here to understand their pain. We're here to assess their pain, that we want to help them get on the right medication, potentially do some alternative therapy, and that we are committed to finding ways to reduce these symptoms that they have. So when we think specifically about pain assessment, the gold standard is a self-report. So we know that for pain, there isn't a specific tool or a blood pressure cuff or a scale physically that we can use to measure someone's pain. So we have to ask them. We have to ask our patients during every shift about their pain. And I know that currently, I think in our documentation for AHN, we don't include pain, but I think we are going to try to add that into Clinicia. Actually, if someone can just put in the chat if it currently is, I think it's not, but just remind me if it's in Clinicia already or not. Good, yes, Fred, I see your comment in there about describing the pain, really good. So this is a good mnemonic. SOCRATES, Socrates, for the site, the onset, the character, if it's radiating, what's aggravating it, the timing, exacerbating, and the site. Yeah, and you mentioned that. Pain is not yet on Clinicia. So we'll make sure in the next few weeks, as we continue to integrate our palliative care reporting and our supportive care reporting, we'll make sure that it gets on there. So the one thing to note that a person, though, who has had pain for a long time, they may not actually show signs of pain. They may look sad or depressed. They may be really quiet. They might be lying or not moving around in their bed. And this could be because the pain is actually beginning to continue to physically affect them and also emotionally affect them, which is why it's very important that we ask our patients about their pain. And we allow them to share about how the pain is affecting them. So we do this through taking a good history. Again, the causes of pain, we know, as we mentioned earlier, can be very wide and different. So we need to make sure we take a good history of a patient's pain. We examine them. So depending on where they've identified their pain is, we need to examine our patients to make sure that there isn't any trauma or there isn't an open wound or swelling in the area. These are all very important. And then if needed, we can also do investigations. So these can be a variety of scans that can be done to rule out a cause of pain. When we ask simple questions about pain, again, this is kind of what Fred had mentioned, but these are some specific questions you can ask. So what does the pain feel like? When does it occur? Are there any treatments that you're currently using to help treat your pain? Where is your pain? So you can ask them specifically where on the body their pain is. Is there a specific time that the pain occurs? Is it occurring in the morning or is it occurring at night? Is it right after their dialysis treatment? How long does it last, the duration? So is it just for 30 minutes or is it all day? Does the pain change? Is it changing based on activity? And again, what do they think is causing the pain? Is it something very specific that causes the pain that they might be able to share with you? We can use this diagram. Again, in clinician may be a little bit difficult, but this is really helpful to help the patient notify you where the pain is. So you could show this image or picture to the patient and ask them to identify where the pain is on their body. It's really helpful as we document pain. There is a scale that we can use for children that are younger or patients that are having difficulty using that number scale we mentioned. And this scale is called the FACES pain scale. So we want to be able to quantify what a patient is experiencing. And we often use scales to do that. So here is the FACES scale. So you would use this scale by saying the following in the speech bubble there. So you would say these faces show how much something can hurt. This face, and you would point at 0, shows no pain. The faces show more and more pain as, up to this one, and that's the number 10. It shows very much pain. Point to the face that shows how much pain you hurt right now. And this type of scale can help people ages 4 and older understand how to describe and share their pain. We do not put the scale up to a patient's face and then we decide how much pain they have. We still need to get them to choose. We still need it to be a self-report of the amount of pain that a patient has. So again, we don't match it to their face. We use it as a self-report. So 0 would be no pain, 2 would be a mild, 4 to 6 would be moderate, and then 8 to 10 would be severe. For the numeric scale, we usually recommend it can be used for children that are 8 years and older. Usually they have a better understanding of numbers by then. And we would describe it saying that 0 is no pain, 5 would be moderate, and 10 would be the worst possible pain. And we would ask them to rate their pain for that day or for the last week on this scale. And this is something we can print out and have in the clinics, and it can be really helpful as we begin to find ways to assess our patient's pain. It's quite important that we prioritize documenting pain. So as we know, pain can be quite complex. And if we don't have a good way of documenting our pain, the pain that the patient has, it can be really difficult for us to know if the treatment that we're recommending is improving or if it's not working well either. So we know from our patients with advanced kidney disease, again, there can be a variety of reasons. These are a bit more specific in terms of the etiology or the cause of the pain. So if you look at the top left corner, the underlying kidney disease can actually cause pain. So there's the variety of causes from the actual kidney disease or the worsening kidney function of our patients. Our treatment is the one in orange. So if we go to the right, here it says treatment of kidney failure. We know that patients can experience cramps, headaches, even pain related to medication or surgery from their dialysis. Debility, which is in the kind of aqua color there, that can be from patients that experience general condition, low immunity, or even malnutrition. And our patients experience pain related to deep muscle tension, sometimes gastritis, obstruction, aspiration, pneumonia. These types of things can cause a lot of pain for our patients. And then in the green is the comorbidity. So patients that have another disease that could be causing pain, but does affect their quality of life. Maybe not specifically related to their kidney disease, but since we see our patients a lot in the clinic, it is helpful if we can find ways also to identify pain such as this and encourage our patients to access treatment and begin to manage the pain that they experience. For patients that are experiencing chronic disease, such as kidney failure, pain we also know can be multidimensional because it can include not only the biological or the physical aspects of pain, but it can also be psychological or even spiritual. For this, we know that analgesics, so medication, shouldn't be the only thing that we do to focus on the treatment for our patients. So As we think about that, we could potentially recommend or include things such as physical therapy, behavioral therapy, or counseling related to cognitive behavioral therapy, or even access to some interventions such as nerve blocks. We know in more urban settings, access to pain specialists is higher. And if you have a patient that has serious chronic pain, we do need to make sure we refer to those teams. We first want to assess and treat any contributing reversible factors. Then we look at the non-pharmacological treatments, as I had mentioned, potentially looking at some topical or very specific treatment to a certain area. And then we can begin to think about the pharmacological treatment for our patients and their pain. When we think specifically about managing pain, these are some basic principles from the WHO or the World Health Organization in how to address pain. So we first want to address pain by using something called the ladder. And this is through the WHO, it's called the pain ladder. And I'll be talking about the different steps for that. We want to make sure that we give pain medication by mouth. We don't want to give IM or even IV medication if a patient is able to manage well their pain and their symptoms by taking oral medication. It does need to be given by the clock. So we know that for pain, we have to give pain medication regularly. Unless the cause has been reversed, we know that patients can continue to have pain also. We need to make sure that the recommendations we give for pain management is for the individual. So we need to think about their specific case. And we need to pay close attention to detail, especially for our kidney failure patients when determining which medications to use. So in the ISN Academy module, we have identified through Dr. Davison and her team that the WHO analgesic ladder needs to be modified, especially for patients with kidney failure. So the original WHO ladder has 3 steps. So you might know that from working with some patients who have cancer. We know that we use a 3-step ladder to manage pain for those patients. But for our kidney failure patients, there is a step that we try to avoid. So the first step for number 1 here in the green is to do a non-opioid plus an adjuvant. So this is if a patient is rating their pain a 4 out of 10 or greater. And this is when they're we can consider using medications such as paracetamol or even some adjuvants for neuropathic pain. If the pain persists or increases, we begin to go up the ladder. And we know for our kidney failure patients, we need to ensure that we actually skip the second step. So here you can see there's an X through this, and this is due to the way that codeine and other medications are metabolized in the kidney failure patient system, which can often lead to underdosing or even overdosing. And this is not safe for our patients. So that's why we avoid step 2. As we go through, and then we would go directly to step 3. So any patient who's experiencing more pain, 5 and higher, we could consider an opioid, as well as the non-opioid that we started, the paracetamol and the adjuvant. And we really want the goal of the pain to be less than 3 out of 10. And this is quite important for our patients that are experiencing pain. We know for our patients with kidney failure, there is a fairly small therapeutic window in which patients experience relief from their pain. But then sometimes they will experience side effects from the medication. So we need to be very careful in terms of how we dose our patients and the medications that they're on. So this is a really important slide in terms of what are the medications that we recommend initially, and then how do we support our patients on this. So we'll start at the top of this chart. So we want to, again, start with adjuvant therapy. So again, most of our patients with kidney failure do experience neuropathic pain. Sometimes it is nociceptive, but neuropathic pain is due to damage in the nerves. And These are some of the recommendations that are given in the dosages. So you can see here, there's gabapentin, pregabalin, and others there with their starting doses. We recommend, if the pain persists, to add that non-opioid. So the acetaminophen, or in our region here, it's called paracetamol. We can give a maximum of 3 grams daily, as well as the adjuvant therapy. It can be stopped if the adjuvant is not working or it's not being tolerated well. It can be stopped. And again, to treat nociceptive pain, we want to use paracetamol or Panadol to treat that. If the pain persists, we do need to consider an opioid. So again, the recommendation from the international community is to start with hydromorphone, but then also consider other medications. We know that in East Africa, hydromorphone is quite difficult, if not possible to access. So starting with low doses of morphine in situations where access to different opioids is limited is also an option. And making sure that we start very low and go slow. And we titrate or we increase the dose based on the pain assessment of the patient. So for neuropathy, here is from the core curriculum from 2020, from the American Journal of Kidney Disease, some other recommendations, as well as the starting doses. So again, these doses don't need to be memorized. These are images and tables that we can definitely print out at the clinics and have potentially in a folder related to pain management. Common side effects are there, and that's something that we need to consider as well as we treat pain in our patients. So these are the 5 principles that we were talking about. By mouth, we need to make sure it is an oral administration. We know that our patients have easy access because oftentimes they have central lines or but it is really to be avoided. We do want to give our medication by the clock. We need to make sure that it's given continuously or to manage pain, because we know that pain continues for many of our patients unless we've been able to reverse the cause of the pain. So starting with low doses and titrating slowly, using the analgesic ladder, and again, remembering to skip the second step. It needs to be the correct dose for our patient, knowing that the amount needed to relieve the pain without specific side effects that the patient is worried about or complaining about. And then definitely attention to detail. We need to make sure we assess regularly. And if there's any side effects that the patients experience, we need to support them. Any patient that is on a opioid needs to be on a laxative. And this is really important because all opioids cause constipation. And it's very important that we support our patients in that. So we can support and treat common side effects of these medications by prescribing stimulant laxatives, such as Senna at bedtime. And then also potentially offering metoclopramide or haloperidol for nausea, which is often temporary. So the nausea and vomiting doesn't often last very long, but maybe the first few days of starting a new medication like morphine. And then generally, patients can feel drowsy or tired, but again, that's also usually temporary. We do need to remember for our kidney failure patients that there is a risk of toxicity due to too much opioids. So patients can experience respiratory depression, pupillary constriction, and myoclonus, also extreme sleepiness. And we know for patients that are in this situation, we need to treat it quickly for our patients that might be opioid toxic. And then the recommendation is there at the bottom. And that can be due to the medication not leaving the system or the dose being too high. As we think about non-pharmacological approaches to pain medication, we've talked a lot about the medication that we can recommend. What are some non-pharmacological things that we can do? First, we need to make sure that we build a therapeutic relationship. So why do we want to do this? We know that having a therapeutic relationship with the patient builds trust. So again, making sure we get down to the eye level of a patient, introducing ourselves, asking something about them, showing that we care about them can really help build that relationship and help our patients share the symptoms with us about how they're feeling and what they're experiencing. What are some, so we'll go back to the chat. What are some non-pharmacological approaches that you've heard of related to pain? So either what are some of the things that your current patients are doing at your clinics or things you've heard in the past that are not related to medications? It's not paracetamol, it's not gabapentin, it's not morphine. What are some things we can do to help our patients manage their pain? Yeah, really good. Massage. Definitely for patients that have muscle pain, this can be really effective and can support relief of the symptom for sure. Yeah, physiotherapy. So making sure that our patients are engaging in some sort of physical activity. Usually that's guided by a therapist. We know our patients sometimes are a little bit older, or they may have experienced limited mobility. Having a physiotherapist support them can really help with pain for sure. Warm or even cold compresses for sure. Yeah. So if you have someone who's had a acute trauma, a cold compress would be really good to reduce any swelling or any pain that's experienced. Sometimes warm compresses for patients that have chronic pain can be helpful too, like a warm, like a hot water bottle. Maybe if they have lower back pain, can be really soothing to the patient. Yeah, these are really good ideas. You're right on the right track for sure. Okay, so for going on a different, a bit of a different angle, we actually can help support our patients through encouraging them with some coping strategies. So generally for older children over the age of 5 and definitely adults, we can actually encourage our patients through deep breathing. So they may be experiencing pain, but with some support of taking some deep breaths and even guided imagery, we know that patients can distract themselves from the chronic symptom, and that can actually really help them experience less pain. So these are some of the physical comforts that you have mentioned in the chat: massage, heat, physiotherapy for sure. Accessing acupressure can also help as well. Here's a bit of a muscle relaxation exercise that you can use. You could print it out and have it with your patients, allowing them to take some deep breaths in and out, turning their attention to their body, focusing on the muscles of their neck, their eyes, their teeth, their chin, shoulders, their stomach, their legs. This exercise goes through the whole body. It helps really relax their muscles and experience the physical calmness through focusing and slowing their breathing. Some people, distraction really works. So reading books, watching TV if they experience pain, listening to music, these things can all help our patients that are experiencing pain, and it's not related to medication. It can be quite effective. All right, so using the pain assessment scale, we would say if 0 is no pain and 10 is the worst pain that you can imagine, how much is your pain right now? So when we do this, when we use the scale to assess our patient's pain, this is exactly what we want to ask them. So if we were to think about it and we had a patient who's experiencing a 9 out of 10 pain, how much pain would that be? Would it be mild or moderate or severe pain? So a 9 out of 10. Would that be something that we would want to address in our patient? So generally for patients that have a 9 out of 10 pain, that is severe pain. Yeah, perfect. So we definitely need to do something about a patient who's experiencing a 9 out of 10 pain. And it's really important that we use these types of scales. So remembering, describing what the scale is, helping a patient to rate their own pain. So making sure that it's a self-reported pain if they're young. If they're between 4 and 8 years old, we can use the FACES scale. And then if they're 8 and older, we can use that numeric scale. We'll just finish the session today to talk about the myths. So when we talk about morphine, there is a myth that we can only give morphine in the last days of a patient's life. But we actually know that morphine can be given for severe pain as soon as the pain appears. And we can always increase the dose of our patients. For our kidney failure patients, again, we need to use low doses of morphine or hydromorphone if we have access to that. But we can use opioids to treat pain. Another myth is that morphine hastens death, or that if we give morphine, the patient will die quicker. We actually know that palliative or supportive care can actually prolong the life of a patient, and using drugs like morphine actually ensures that patients have better quality of life, and we reduce their suffering, or we relieve their suffering of pain. And then there's another myth that morphine causes addiction. So this is quite a very strong myth, that morphine causes addiction. For our patients who have pain, they will not become addicted to morphine because of the pain that they're experiencing. We know that patients that are on some opioids for short periods of time and then their pain has stopped, sometimes can have issues related to addiction. But for our patients that have chronic health issues and chronic pain, we know that those types of patients will not become addicted to morphine because they have the symptom, and we need to be very diligent in treating the pain that they have. So I wanted to put us into groups, but I think because we're a small group, I wanted to talk about two different situations. So I want to think about how would we assess pain in a patient who's had advanced stomach cancer and also kidney failure? How would we adjust the dose of any opioids that are given? And then what's a good starting dose for opioids to treat the pain that they would have? So let me put this in the chat. Dr. Mazar, what do you guys usually do on your team to treat severe pain, especially in a case like this? Or would someone else like to take a try at it? Do any of your patients currently take strong pain medication like morphine, low dose morphine?
I know it's common. It's very common in Rwanda and Kenya. Apparently, in Tanzania, I have very few patients in morphine. I haven't prescribed any to any of my patients. So maybe they will hear
Okay.
that. Yeah.
Maybe because of access to the drugs, maybe?
Yeah, I think so. The access, they are not really available in most of the hospitals.
And what are some of the common dosages that you see for the patients that are on?
Jefferson, I don't know if you have seen any patient with this.
So generally for patients that are experiencing pain, we do, like Dr. Mazar said, want to consider the side effects. I would be curious to know the life-threatening side effects. What are those life-threatening side effects? There's very common side effects. What are the ones that you are, or the teams are concerned about, Dr. Mazar? Is it the respiratory depression?
Yeah, I think so. I've seen I think that's the most feared. There is respiratory depression in most of the patient.
So generally, when we give really low doses of opioids, we aren't as concerned about the respiratory depression. We know that we need to monitor patients that start on opioid medication, but not treating someone who has severe pain is also quite serious. And I think that the worries and the concerns that we have as healthcare providers related to the respiratory depression will outweigh a patient who's experiencing severe pain. We know that patients, again, as I mentioned earlier, who have severe pain that's not treated, oftentimes experiencing also anxiety, depression, they don't eat, they probably don't come to dialysis regularly. It affects all aspects of their life. So in our situation in Kenya, we do have access to oral morphine, and in all of our county level facilities, there is morphine that's a liquid. So we should be able to access that, and we can recommend a low a low dose of morphine for our patients, especially for those that are not currently taking any other opioids. We can start them at a very low dose of 2.5 milligrams every 4 hours. But as I had mentioned earlier, the gold standard is opioids that are better excreted through the system. So through the kidneys. And that is the medication I had mentioned earlier, which is hydromorphone. So a starting dose of 0.5 milligrams PO every 4 to 6 hours of hydromorphone. Does anybody know of patients currently using pain medications such as gabapentin or paracetamol? Or is anyone taking care of patients that have pain?
I would say 3 or 4 of my patients are currently on pain medications. The pregabalin, some of them are using the topical like diclofenac gel.
And are any of the patients taking medication like tramadol? I know sometimes tramadol is easy to get over the counter or just from the normal drugstore. It can be a little bit.
It's readily available. I think it's readily available. I think some patient it's easier to get tramadol when they buy like in outpatient setting, but in the hospitals, the
Yeah.
long term like pregabalin they are mostly used.
Okay, I'll just put up the last question for the session for today. What do we normally do to plan for our patients who have neuropathic pain? So that is related to patients that are experiencing numbness or burning or tingling. Usually it's in their extremities, in their feet, in their fingers. Yeah, Fred, so mostly the neuropathic pain is for the diabetic patients, for sure, with the neuropathies. They're oftentimes on medication, which is good. Betapin, which is in Kenya, is that a common one that people are using? Must be. So the one thing we need to continue to encourage our patients is to ensure that they notify us when they are taking even over-the-counter or non-prescription medications, because it can be quite important for us when we look at their medications and look at their dialysis. So betapin, it looks like here, has codeine in it. So we actually should encourage our patients to avoid this specific tablet due to the fact that there's codeine in it, and can be difficult for them to excrete the metabolites for that. Is it quite common for the patients to be on that medication?
Apparently, we don't have that in Tanzania. But it sounds to be very strong considering the combination.
Yeah, it's a bit tricky. So with betapin, of course, a patient would experience better pain management, but we need to be careful because that means that there would be more codeine in their system for longer periods of time because of the way it's excreted. So we can definitely bring this up with Dr. Yuri and some of the other medical team, even Dr. Lloyd, to see what the recommendations are. Potentially not taking it as often as it's recommended. And for a patient that is taking betapin, probably a very thorough pain assessment to understand the causes. Maybe they need to start on some of the adjuvant treatments. Morphine is available in Kenya. Fred, I don't know where you're working. Which country are you in, Fred? You're in Kenya. Okay, so oral morphine is available in Kenya. All the county facilities that have palliative care units have access to morphine, and KEMSA delivers it to the different county level facilities. So also places like Kijabe and other mission facilities do have morphine. Again, we would need to, I think probably our teams are not necessarily aware of that and sensitized to the fact that we can access morphine in Kenya. So that's what we'll be kind of doing as a group and continuing to sensitize related to the proper assessments and then making sure our patients get on the right medication. I will follow up with the medical team related to the betapine. Dr. Mazar, do you have experience with codeine, using codeine for patients? Yes, of course, Lillian, you are right. We need to have prescriptions. Any opioid, even betapine, should really have a prescription. They shouldn't be giving codeine out. Our medical officers would be able to write a prescription for that, and the palliative care units in the county level facilities are able to dispense the morphine because they usually have a team. Okay, Margaret, really good. So, so you tried to give pain medication, and then if there's no relief, definitely recommending that the patient go for further investigation and consultation. So that's also really important. If we've tried something basic, then we need to make sure we escalate that, because again, untreated pain is very common in our patients and can lead to really poor quality of life. Okay, so Anson was using morphine a while back for a palliative patient. Yeah, and in our center, yeah. So in our AHN centers, we don't have access to morphine, but most of our clinics are connected to a partner facility. So I know for sure in Kenya, locations such as Kijabe, even some of the Presbyterian centers like Kikuyu, they would have access to morphine. Again, identifying patients that need it, and then working together to get a regular prescription and monitoring that and reassessing, making sure the side effects are managed well is really, really important. So does anybody have any other questions? I think it was a good discussion today. I'm going to follow up related to the betapine. And I can message on the WhatsApp group. Next week, we are going to be focusing on, next week, we're going to be talking about communication and patient-centered care. And we are going to begin the signups for case presentations. So I'm going to share around an example of what a case would look like. So it would be patient, kind of diagnosis, a bit of history. And then we are going to begin to use the supportive care model to explain more information about the patient and really understand ways to provide supportive care. So I will be sharing around an example of that this week. And then we'll start the signups next week in terms of identifying a patient you'd like to share about. It's not going to be long. It will probably be around 5 or 6 slides. As we get further on in the course, we can obviously be more detailed, but I don't want it to be stressful for the team. So, so we'll just ask you to share a few slides, and then we'll have a discussion about the case. Next week, we'll be having someone join us for a few minutes. She's a palliative care nurse that's been connected with the team in Voi, and she just wanted to explain a little bit more about their hospice. So that'll be nice. Her name is Muriel. She's a nurse in Kenya, supporting county level palliative care. So she'll join us next week. And I guess if we don't have any further questions, thank you for joining us today. I'll follow up with those few things on WhatsApp.